Hello everyone, and welcome to our webinar focusing on cardiothoracic inflammatory pathologies in patients listed for transplantation. So we are really grateful to have three excellent speakers who have kindly given up their time to talk us through some specific issues. You can leave questions in the chat as we go, or you can save them for the dedicated Q&A right at the end. So let's start with our first talk.
Good evening. Good day to everyone. I'm Marny Fedrigo, and I introduce the first speaker, Professor Annette Jackson. She's an associate professor in integrative immunology at the Duke University. She has a great experience with immunology and xenotransplant and solid organ transplantation, also in kidney and liver. Her topic is immunology perspective, the complex inflammatory milieu. Professor Jackson, the stage is yours.
Thank you very much. I'm providing the immunologist perspective, the complex inflammatory milieu. And so I will be using some fabulous review articles, this in Frontier Medicine, talking about the different phenotypes of end-stage lung disease. Connective tissue diseases are a broad array of diseases with different clinical manifestations. To an immunologist, they're highlighted by T and B cell infiltrates, as well as the detection of autoantibodies in the sera. These patients are treated with immunosuppressive agents, which are thought to halt immune activity and halt or at least delay progression of disease. Systemic sarcosis and ankylosing spondylitis are HLA-associated diseases. HLA-associated diseases are believed to signify the importance of the antigen in the inciting immune response, such that a particular HLA allele is more efficient or better able to present the antigen, whether it be an infectious antigen or an autoantigen, to the T cell immunity and initiate immune activation and disease progression. Autoantibodies are also a hallmark of end-stage organ failure. Autoreactive T cells and autoreactive B cells are removed from the repertoire during ontogeny, but they do remain at low frequency. At the time of tissue injury, autoantigens are released in the context of an inflammatory milieu, which allows antigen-presenting cells such as macrophages, monocytes, B cells, and dendritic cells to take up the autoantigen, and in the inflammatory milieu, differentiate into productive antigen-presenting cells. Interaction of an autoreactive B and T cell can lead to germinal center formation and autoantibody production. There is data to suggest that these autoantibodies can be deleterious post-transplant, and especially when they're detected in the presence of HLA-DSA. And this is a topic of ongoing study by the AST/ABHI STAR working group in 2022 and a new report coming out in 2025. Idiopathic pulmonary fibrosis is believed to be a result of ongoing endothelial cell injury and secretion of TGF-beta, which recruits fibroblasts into the lung. The fibroblasts undergo differentiation into myofibroblasts, which cause excessive deposition of collagen and extracellular matrix proteins. Neutrophils are believed to be part of the acute phase and actually contribute to the fibrotic process. And this disease is also hallmarked by the presence of Th2 pro-fibrotic cytokines and humoral involvement. Sarcoidosis is identified through the identification of a granuloma or an aggregate of cells from the innate and adaptive immune system. The antigen can be microbial or non-microbial, and it's thought to, in the early phases, be promoted by a Th1 response, which then switched to the pro-fibrotic Th2 response. This disease also is hallmarked by the presence of autoantibodies and circulating immune complexes. So in all of these end-stage diseases, the diagnoses come late, and this is common in an autoimmune disease state. We diagnose these diseases after tissue injury and after immune dysregulation is in place. And so what is needed is a better understanding of the pathogenesis of these diseases, both the genetic and environmental factors. And I think we have new tools that are being used that can help us understand the pathogenesis of these multiple diseases. This is single-cell data that's being pulled together by many collaborators to form organ cell atlases. And in this UMAP in the upper right corner, I thought it was very telling that when you take the lung and look at the composition based on 4 basic cell components, the immune cell component shown in green makes up a significant portion of the lung tissue. This is a look at samples from over 100 individuals, showing that the immune, myeloid, and lymphoid cells shown in green are really focused within the parenchyma, but there is variability based on the lung sample tested, showing the real dynamic interaction between the immune system and the lung. Heart failure is also thought to be due to systemic inflammation. The cardiomyocytes undergo cell death or hypertrophy. Fibroblasts are activated, endothelial cells are activated, and there's an influx of immune cells, both adaptive and innate. Myocarditis can be triggered through many different antigen sources, infectious agents, allergens, alloantigens in the post-transplant setting, autoantigens, as well as drugs and other environmental exposures such as heavy metals. Once infectious agents have been ruled out, the other testing is rather vague. Clinicians use elevated white counts as well as elevated detection of pro-inflammatory agents in the blood. However, it's not currently recommended as standard of care to test for elevated anti-cardiac antibodies. Single-cell sequencing is also being done, and the heart atlas is also being formed. This shows the different cellular components of the different regions of the heart. And in contrast to the lung, the lymphocytes shown in green and macrophages in pink make up really a smaller proportion of the heart, overall heart tissue. Single-cell analysis is also helping with diagnostics. This is a paper in which they performed single-cell analysis on biopsy tissue and found a very strong transcriptomic signature for giant cell myocarditis. And then less mentioned in the paper, but also exciting, was the signatures that were found for lymphocytic myocarditis versus allograft rejection, 2 phenotypes that are very difficult to discern using histology alone. This principal component analysis on the lower left shows that in brown, the lymphocytic myocarditis can be distinguished from allograft rejection. And I think the new data that's coming on the horizon is the marriage of spatial transcriptomics with gene transcriptomics. And it really marries the beauty of anatomical pathology along with these new molecular assays, such that we can not only understand what cells are present and what genes they're expressing, but we can understand the cell-cell interaction and interplay that happens. And I think this is going to be particularly important in understanding how the immune system interacts with our native organs within healthy conditions and within disease conditions. And so in summary, end-stage heart and lung disease is due to inflammation that involves both innate and adaptive immunity. There is a loss of tolerance as seen by the evidence of autoantibody in the circulation, and definitely a loss of regulatory mechanisms. However, there's new unbiased molecular approaches that are improving our ability to diagnose these pathologies and perhaps lead to a better understanding of the pathogenesis and new potential therapeutic targets. The end goal, of course, is disease prevention, or at least early intervention prior to all of the tissue damage and the immune dysregulation. And I believe this will also come from these newer studies in which they're combining GWAS data that includes HLA typing along with transcriptomic data to understand disease pathogenesis, so that we'll be able to identify what patients are at risk, and we'll be able to diagnose them before permanent tissue damage. And so that is my whirlwind through the immunology of end-stage organ failure.
Yeah, Professor Jackson, it's a great presentation. Lauren.
Yes, I'll introduce our next speaker, the wonderful Professor Calabrese. So she is a thoracic pathologist based in Padua, and her interests include interstitial lung disease, transplant, and molecular pathology.
Good morning, good afternoon, good evening, everybody. Thanks, Chairs, for your kind introduction. And above all, thanks all the ISHLT organizers for the kind invitation to take part of this very interesting webinar. About my subject, I do not have any conflict of interest. So here are the key points of my talk. I'm going first to briefly focus on why is so important a careful study of external lungs. And then I spend more words on what do we need to look for in presence of inflammation in end-stage lung diseases and consequently in post-transplant biopsies. Particularly, I'm going to focus on inflammation in different forms of diffuse parenchymal lung disease, inflammation related to infection, and finally, I leave you my take-home message. So why is it so important a careful study of external lung? Native lungs represent a great source, the best opportunity for us, for pathologists, to study whole lungs as well as autopsy specimens, but even more better as external lungs are not affected by superimposed agonal complications usually seen in autopsy specimens. For that is so crucial to appropriately sample, preserve external lungs or in general external organs. Indeed, our community, pathology community, is working on drafted guidelines with the main aim of standardizing the procedure. This is our SOAP, the panel summarizing main steps. I'm showing you only to remark how extensive lung sampling is, just starting from surgery room up to pathology lab. But why is it so important a careful study of native lungs? Here listed the major reasons, but surely the most important one is to provide a definite diagnosis of the disease that still now represent a good audit for clinicians. Indeed, several lung transplant centers have reported a discrepancy rate between the clinical and the pathological diagnosis from 18 to 10%, and now our recent update is about 7%, not so small. Moreover, because major discrepancy may have a significant impact on graft outcome. But what do we need to look for in presence of inflammation in diffuse parenchymal lung disease with usual interstitial pneumonia pattern. DPLD with UIP pattern include a large box of diseases, usual interstitial pneumonia pattern characterized by temporal and spatial heterogeneity of lesions with subpleural paraseptal fibrosis alternated to quite normal lung parenchyma and neofibrogenesis, is the typical pattern of idiopathic pulmonary fibrosis, but this pattern may be detected in several other fibrosing interstitial lung disease with different etiologies. And now our knowledge is significantly improved thanks to the contribution of several milestone papers and statements, so that we are able now with a high confidence to recognize UIP in IPF versus secondary UIP. In other words, pathology carefully search for details. And one of the most important details is just inflammation, the type of inflammation and the topography of inflammation. So if, for example, we see inflammation located in central lobular area with feature of lymphocytic bronchiolitis or bronchitis, sparse abortive granulomas, giant cell with inclusions, peribronchial metaplasia, our more confident diagnosis is UIP in fibrosing hypersensitivity pneumonitis. Fibrosing hypersensitivity pneumonitis is an infrequent indication for lung transplantation. Unfortunately, we have a very few studies that compare the fibrosing hypersensitivity pneumonitis versus other interstitial lung disease, in particular idiopathic pulmonary fibrosis. The two studies that included an adequate number of patients report a better outcome compared to IPF. But a case study, moreover, highlighted that fibrosing hypersensitivity pneumonitis is a frequent and unexpected diagnosis. And this is also my personal experience. So what do we need to look for in post-transplant biopsy of these patients? Case study report a low rate of acrocellular rejection, and they report a relapsing disease in 6% of cases, likely due to an unaware exposure to the offending antigen causing the previous disease. So in other words, when we detected an unexpected diagnosis of fibrosing hypersensitivity pneumonitis, is mandatory for us, for pathologists, to inform a transplant specialist. And to highlight this important aspect, let me briefly show you this index case. The case concerns a young no-smoker male, professional brass instrument player. The patient was transplanted in Strasbourg with a diagnosis of genetic-related IPF due to a rare surfactant protein C heterozygous mutation detected in genetic screening. I had the opportunity to analyze lung samples during my one-year activity there, and while upper lobe showed the typical feature of UIP, when we focused on less remodeled lung parenchyma, we detected all the previous lesions I show you. In other words, inflammation. Inflammation around small and large airways, sparse abortive granulomas, peribronchial metaplasia. So our final histological diagnosis was a fibrosing hypersensitivity pneumonitis instead of idiopathic pulmonary fibrosis, better matched with the clinical phenotype. I remind you the patient was a young adult, no smoker, and a professional brass instrument player. Indeed, several articles have reported hypersensitivity pneumonitis in wind musicians related to the presence of a contaminant microorganism inside the instrument. Indeed, in our case, a microbiological analysis detected a contamination with fungus, Fusarium oxysporum, inside the instrument. So if you want to read more detail about this nice case, you can follow this, our reference. Anyway, the patient had a prompt recovery. The patient didn't develop any significant post-transplant complication in the 2 years after transplantation. But transplant specialists, well informed about the right diagnosis, strongly recommend to use standard clinical methods to prevent relapsing disease, as the patient is a professional brass instrument player. So inflammation may be detected in another DPLD with UIP pattern. And when inflammation is detected everywhere, showing features with aggregation in lymphoid follicles, with well-evident germinal centers, pleuritis, multiple areas of NSIP feature along few blindly developed fibroblastic foci and vessel remodeling, our more confident diagnosis is UIP in connective tissue disease. And the connective tissue disease is a rare indication for lung transplantation. Now pathologists are experiencing a less rate of discrepancy between the clinical and the pathological diagnosis. And this is due to a more accurate and wider pre-transplant immunological screening performed by pulmonologists. But what do we need to look for in post-transplant biopsies? As several patients, particularly scleroderma, are suffering from esophageal dysmotility, we have to carefully monitor GER-related lung aspiration, appearing as foreign body granulomas or high lipid-laden macrophage index in oil red stained bronchial barrel lavage. But we need to be alert for other complications as infections, because these patients had a high long-term steroid use during pre-transplant life, and increased immunological disorders, as these patients, who have previously listened, have a high rate of preformed anti-ISHLT antibodies. And in anecdotic cases have been reported also relapsing disease in the setting of a polymyosite or antisynthetase. What we need to look for in inflammation in granulomatous DPLD as a sarcoidosis. Sarcoidosis is a little bit more frequent than previously described interstitial lung disease, accounting more than 7% of ILDs. The final diagnosis of end-stage sarcoidosis still remain for pathologists a challenging diagnosis. In this great study by Zhang, were carefully listed all the key features we have to focus on. Moreover, the distribution of fibrosis mainly affecting the upper lobe where the disease usually starts, and overall we have to carefully evaluate the presence of granuloma. Granulomas that can appear as nodular concentric fibrosis in the so-called burnout sarcoidosis, but also we can see active granuloma that are similar those we usually see in sarcoidosis, in non-end-stage sarcoidosis. And when we see active granuloma, including granulomatous vasculitis, this should always be carefully reported in our diagnosis, because it has been demonstrated that these patients are at higher risk of recurrence. Other lesions may be detected as bronchiectasis, sometimes with superimposed infections, emphysema, or through UIP pattern. But what do we need to look for in sarcoidosis, in post-transplant biopsy of patients with sarcoidosis? Moreover, relapsing disease. In this recent study by French group, the authors report a lower frequency in the last decade compared to the previous one, and the authors hypothesize this related to a changing of immunosuppressive therapy. And how usually appear the recurrent form of sarcoidosis. Usually there are more frequent naked granulomas, in other words, without a clear-cut signs of lymphoid coughing. But the other features are equally present, in other words, giant cells with inclusions. Anyway, when we see granuloma in post-transplant biopsy, we have to exclude other etiologies, moreover infections, and then we have to use all our ancillary tools, spatial stains and the molecular analysis. Concerning immunological complications, there are contradictory data in the literature. The last study by Banga reported lower incidence of cellular rejection, and the authors hypothesized related to a changing of immunosuppressive therapy or reduced activity of dendritic cells, quite typical in sarcoidosis. Finally, inflammation may be detected in infection. Infections may be seen in all end-stage diseases, moreover in obstructive form, bronchiectasis and cystic fibrosis. When infections are detected as unexpected infections, these are usually in the setting of fungal or mycobacterial infections. And when detected as an invasive form, and especially are unexpected, we have to promptly inform transplant physicians. Why? Because these infections have been demonstrated at high risk of recurrence and impacting on graft outcome. But anyway, what is our important task? When we detected an infection, we have to carefully characterize the etiology of infections using all our ancillary tools. And for that, let me show you this index case. The case concerns a young female of 20-year-old transplanted several years ago in our Center for Cystic Fibrosis. At time of transplantation was known only colonization with Pseudomonas, as usually is in these patients. But when we see the explant lung, we detected several necrotizing granuloma, some of them mainly localized in close to the cystic lesions. We performed all the spatial stains, acid fast stain for mycobacterial, pus, Grocco, but were all negative. But we proceed using a more sensitive tool, nested PCR for mycobacterial and microdissected granuloma, and the analysis was positive, and the amplicon was then sequencing, revealing a high homology with Mycobacteria simia. The patient was not treated with the specific prophylaxis because the patient had a longer ICU stay due to severe primary graft dysfunction she developed immediately after transplantation. And 2 months after lung transplantation, a scheduled visit, the patient showed a decline of FEV1. The CT scan showed multiple GGO, ground-glass opacity with an excavation, and transbronchial biopsy in at least 2 fragments aggregate of granuloma associated to organized pneumonia. We soon proceeded with nested PCR, and the nested PCR and gene sequence again revealing the presence of Mycobacteria simia. At that time, bronchial vero lavage was positive, and antibiogram revealed the specific drugs, and the patient was successfully treated. So here are my key takeaways. The presence of inflammation in explant lungs always requires careful evaluation, particularly when it is associated with the UIP pattern, as this can mask discrepancy with the clinical diagnosis. When we have a granulomatous DPLD sarcoidosis, in this case, we have to provide a more informative report describing all lesions, particularly the active lesions, as these patients are at higher risk of relapsing. And when inflammation is associated to infective disease, in this case, we need to specifically characterize the etiology using all our tools, including the most sensitive one. And what do we need to look for in post-transplant biopsies? We need to increase alertness towards different graft complications, recurrence, lung aspiration, infections, immunological events. Too much work for us, but surely, hopefully, so crucial and helpful for our patients. Thank you for your kind attention. I'm glad to discuss your question or comments at the end of the webinar.
Thank you, Professor Calabrese. Your great presentation and underlined and great importance of pathologists in the diagnosis of infection pre and post-transplant. I remind the audience to type your question on the chat, and then we move to our third speaker, Dr. Maya Neckenhorst. She is a pathologist. She works at the Medical University of Vienna. She had experience on kidney pathology, but also in cardiovascular pathology with a focus on infection disease and translational transplant pathologies. So Maya, the audience is yours.
Yeah, thank you for the introduction, Marny. So I'm going to be talking about what we as pathologists have to look for in end-stage heart disease and in cardiac post-transplant biopsies. So there's quite a few important inflammatory diseases that do lead to end-stage heart disease. In this talk, I'm going to be focusing on lymphocytic myocarditis, giant cell myocarditis, sarcoidosis, and Chagas disease. For the non-pathologists, here's just a very, very quick reminder of what we want normal cardiac tissue to look like. So this is a biopsy, and you can see that the myocytes are quite close to each other. There's not really much interstitial space. And the myocytes are roughly the same size and shape, and the nuclei are also about the same size. In contrast to that, here you can see an example of lymphocytic myocarditis. So up in this corner here, we've got normal myocardium, and then here you can see that the architecture is disrupted by an infiltrate of mostly CD3 positive lymphocytes, and there's also going to be a bit of CD68 positive macrophages in there. And they do cause myocyte damage here, so that the architecture as a whole seems disrupted. For some lymphocytic myocarditis cases, they have been associated with the detection of viral genomes. And there is studies that show that when lymphocytic myocarditis is associated with viral genomes, that those cases do respond worse to immunosuppressive therapy. The other disease I want to highlight today is giant cell myocarditis. The hallmark cells of giant cell myocarditis are the giant cells that you can see here. They also come along with a lymphocytic infiltrate, but these are really what you want to look for. And as you might be able to guess from this picture, you can see leftover myocardium here and here, but the rest has been destroyed by the inflammation. So giant cell myocarditis tends to be more aggressive. Patients tend to present with an acute onset of symptoms. There's usually severe myocardial injury that goes along with this. And these patients have a much worse outcome than their counterpart disease that also has giant cells, which we've heard mentioned before, sarcoidosis. And before the advent of tacrolimus and antisymocyte globulin, around 90% of these patients with giant cell myocarditis either flat out died or required transplantation. Numbers are still not great, but they have improved since then. This is what sarcoidosis looks like in the heart. So we've seen it in the lung, and it looks comparable in the heart. We have all giant cells here and here. And what these tend to do in sarcoidosis is they form non-caseating granulomas. Again, this is far less aggressive than giant cell myocarditis. However, in the sarcoidosis subgroup of patients, cardiac sarcoidosis is the second leading cause after respiratory failure. So within this subgroup of patients, it is a relevant thing to diagnose. which tends to be in clinical practice a bit hard to do. There's two studies here that I've picked out that highlight that there's quite a bit of discrepancy between the diagnosis of sarcoidosis clinically and the diagnosis on explant. So in this study by Roberts et al., all cases of sarcoidosis that they found, which is 8 cases, were misdiagnosed prior to explantation as simply non-ischemic cardiomyopathy. And the patient cohort from Raisi, Giglo et al. Did not fare much better. 11 out of 13 cases here were misdiagnosed as mostly as dilated cardiomyopathy. And the diagnosis of sarcoidosis was only made after the transplantation based on the explant. And the last disease that I want to mention is Chagas disease. It is caused by a parasite called Trypanosoma cruzi. And in South America, it is one of the main leading causes of heart failure, affecting around 7 million people worldwide. The numbers vary a bit depending on which study you look at. And most of them are located in South America. And Chagas disease has 2 phases. There's the acute phase that comes along with a symptomatic patient, parasitemia, and importantly, because this is something we can spot as pathologists, there is proliferation of one form of the parasite. So the life cycle of Trypanosoma cruzi involves the kissing bug, and it has a couple of forms. But what we're going to see in the tissue, if we look closely, that's these so-called amastigote forms, and they can proliferate in quite a few types of cells, but here you can see them living in a myocyte. And this acute phase is then usually followed by the indeterminate phase. So patients are asymptomatic, there's low parasitemia in the blood, and then suddenly, decades later, around 20 to 30% of patients will suddenly develop cardiac symptoms. And if you think these are going to be hard to spot, this is what chronic Chagas disease looks like. And I apologize for the quality of this image. It's a bit blurry. But what you might be able to gather, this can easily be confused with something else, lymphocytic myocarditis maybe. So if you have no clinical background and no info, chronic Chagas can be a big pitfall, and cause quite a few troubles. Okay, so how do these people fare without a transplantation then? So for all of the data that I'm presenting, I would like you to keep in mind that these are, in the grand scheme of things, rather rare diseases, which means that sample sizes in these studies are always limited. So everything is taken to be taken with a bit of a grain of salt. I hope I picked representative studies. So for lymphocytic myocarditis, a 5-year survival rate or transplant-free survival rate of around 50 to 60% seems to be where they stand. Giant cell myocarditis patients fare worse with a transplant-free survival rate at 5 years of 42%. And then sarcoidosis does the best with a transplant-free survival rate of 90% at 5 years. I couldn't find any reliable equivalent data for Chagas disease. It is a disease that is highly associated with poverty, and by extension, therefore, there's far less research, far less money being invested into this. I did find a study by Freitas et al. That showed that patient had a higher mortality compared to other reasons of heart failure, and this ranged from 2.27 to 2.98 relative risk, depending on what they were comparing it to. Yeah, but what do we do when these people don't survive without a transplant? So after transplantation, if you know that this is the reason for transplant, then besides rejection, what you're going to be looking for is clearly recurrence of disease, which is going to be a bit of an issue for lymphocytic myocarditis, simply because there is no practical way to tell the difference between lymphocytic myocardium and rejection. This is just going to look the same. Transplantation in myocarditis has historically been controversially discussed. in older literature, they found an increase in rejection episodes of patients transplanted for lymphocytic myocarditis, and also lower post-transplant survival rates. These are quite stark differences, actually. This was back then attributed to the persistence of immunologic activity from the myocarditis. However, recent studies did not confirm this finding. So as the literature currently stands, these patients do not have a worse outcome if they are being transplanted. For giant cell myocarditis, I could find some numbers. So I found this lovely study that has a case report and a solid literature review. So in their study, what they saw is they have a giant cell myocarditis recurrence rate of 8%. Mean age of recurrence was 42 years. And the mean time to recurrence was rather short, with 1.8 years. For the recurrence of giant cell myocarditis in transplants, gender does not seem to be playing a role. The gender distribution was equal. An interesting side note is that around 35% also had additional acute cellular rejection, and mortality was 15%. That is, however, in total numbers, only 3 out of a total of only 20 patients. Recurrence rate for sarcoidosis was a bit less, so there's a recurrence rate of 5%, with a mean age of recurrence of 48 years, and a slightly longer time to recurrence, with a mean of 3 years. Gender does seem to be playing a role in the recurrence of sarcoidosis. The vast majority of recurrence cases were male patients, with 83%. These patients also had an even higher rate of additional acute cellular rejection, was up to 50%. And mortality was 30%. This is, however, still only 3 patients out of a total of 10 patients. Again, for Chagas disease, the data is a bit more grainy. What is known is that immunosuppression can definitely reactivate trypanosoma cruzi infection. And generally, it's advisable to keep these patients at the lowest possible dose of immunosuppression, which then obviously increases the risk of rejection. So that's a bit of a careful gamble that one has to play. The problem with this is that the parasites themselves are difficult to identify, and the reactivation of disease can simply look like a 2 or 3 year rejection. And if you know that your patient has a history of Chagas disease, obviously go looking for the nests of mastigodes. If your center has it, there is a trypanosoma cruzi immunohistochemistry, and PCR is a great ancillary testing to help you sort it out, because disease reactivation is rather common in this patient group, with up to 45% of recurrence within the first year post-transplant. Another thing that might help you, if your clinicians tell you the clinical symptoms of the patient, so anything that doesn't quite fit the rejection pattern. There is skin nodules that, if they appear, are quite typical for Chagas disease. Again, brain abscesses, probably you're going to start thinking this could be something else than rejection. Jaundice, another thing that you would not normally see. So there are clinical hints if you have access to clinical information. If Chagas disease is treated properly, the mortality is very, very low. The challenge is to detect it. There's specific medication for Chagas disease that works quite well. Okay, so to sum it all up, what are the challenges in diagnosing recurrence of disease after transplantation? The true rates of recurrence aren't really known. All of these diseases have a bit of an invasive nature to them. You can miss them on biopsy. A lot of the times an autopsy is not conducted. And additionally, if you've noticed, all of the data that I've shown you if it looked at rejection, has been about cellular rejection. So we don't know the rate of inflammatory diseases influencing antibody-mediated rejection, so that's another black box. And some of these recurrence of diseases can look like rejection, so there can be confusion between rejection and recurrence on biopsy. An outlook to the future, cell-free DNA and improved imaging modalities might be helpful in the future, but as we currently stand, it's really just pathologists' keen eye and awareness of these potential diseases that's going to help the patient. And with that, I am finished, and I'd be happy to take any questions.
Thank you, Maya. It's great presentation, and also at the end, a lot of open questions on biopsy and the capacity for pathologists to diagnose infection versus rejection. So it's quite very interesting, very interesting. I think that, Lauren, we start with discussion.
Yep.
We have a lot of questions on the chat. We can start two questions for Professor Jackson. Sorry. The first one from Professor Angelini, University of Padua. Are there a difference between giant cell myocarditis and the lymphocytic myocarditis from a molecular point of view?
Yes, I don't want to overstate the single paper that I showed, but the transcriptomic signature did identify significant differences. So yes, I think the molecular transcriptomics will be very helpful in diagnosing the difference between giant cell and the lymphocytic myocarditis.
I add another question to this one. Do you think that the molecular point of view, the molecular profile in this case, is have a practical way in the little future or not?
I do, but I think these studies these are brand new studies just being published in 2023, and so they need to be validated. Especially the study I showed, it was very few biopsies. And so they certainly need to be validated, but I think the data look promising. Much easier to see the giant cells from normal or from rejection. The lymphocytic myocarditis was much more similar to rejection. So I think it's going to take larger numbers to be able to determine the sensitivity and specificity of being able to separate those diagnoses, but it does look hopeful. I don't know if Maja has an opinion on the current state of affairs in differentiating them using histopathology.
Yes, thank you. And the last question for you from Professor Roden. Is there an immunologic explanation with sarcoidosis, particularly as it occurs so relatively frequently and sometimes quite early after lung or heart transplantation in the allograft when compared to other diseases?
Yes, I would invite my co-speakers to comment on this as well. I think there's an older study from 2005 that suggests that that these granulomas are recipient in origin. And so it seems to be the dysfunction of the recipient's immune response that causes the recurrence. And that there has been difference in incidences with newer immunosuppressants. And I don't know if Fiorella or Maja have comments on their center's experience.
Yes, you say right. This is now the current view. And moreover, I would like to add that the OK is a frequent recurrent disease, but it is not alone because several other diseases now we are discovering are relapsing. And it's not always so early because has been described, sarcoidosis, recurrent sarcoidosis, also 2 years after lung transplantation. So it's very complex, the mechanism. Now the view at the relapsing disease is changing due to the changing of immunosuppressive regimen. But we will see what happens in the future.
Yeah, I agree. I think just everything is a bit limited by the small sample size. I do think it'd be very, very interesting to do a study where we look at the different immunosuppressive regimen, with the challenge of there just being not that many cases.
Yeah. Great. I'll move on to some of the questions we had for Fiorella. So one question we had, so what is the significance of follicular lymphocytic aggregates in lung pathology?
Great question. Okay, because lymphocytic aggregates are frequently seen in end-stage disease. Okay, what is important for us is just to focus on the topography of lymphoid follicles. In other words, for example, in a COPD or an obstructive disease or in smoking-related disease, follicles are frequently detected and are just close to the airway. In UIP-IPF, we can see follicles as well, but these are usually detected in just close to the honeycombing. So these are a sort of a reaction to mucosis or superimposed infection in honeycombing lesions. But when we detect follicles out from honeycombing in interstitial space, especially follicles showing as a tertiary lymphoid follicles, in other words, with well-evident germinal centers. These are usually more frequently associated to autoimmune stigma, in other words, in connective tissue disease of any type of connective tissue disease. So are really very frequently detected in end-stage disease, but the topography and the type of follicles are extremely important.
Thank you. And the second, a good practical question. So what is your protocol when you're working up explanted lungs in terms of the sections that you take?
We usually are really generously sampling. We performed 3 samples per lobe. And in case of fibrous interstitial lung disease, we preferentially, one of the sample are usually taken in a lesser remodeled lung parenchyma, because if we want to discover ancillary findings, in other words, the so-called details that distinguish UIP primary from secondary, we have to sample lesser remodeling lung parenchyma. So 3 samples for lobe, then hilar structure. Usually lung arrive in our lab fresh because we use an inflation and perfusion through the bronchial tract with formalin. And concerning the fresh samples are usually taken from our surgeon. We thank our thoracic surgeons because they usually do a great job, because they usually perform the small fragment, usually put in medium for culture, and another small preserved in RNA later, then stored in our biobank.
So just to check, did you, the clinicians, so at the time that they're transplanting, do they take samples from the explant and send it off for an infectious workup?
Yes, yes. But for infection, they usually sample small fragments and they put in a medium culture, but preferentially they use the bronchoaspirate, bronchoalveolar lavage from both from recipient and donor, and they immediately send to our microbiologist.
And there are 2 questions for Dr. Nakenhorst. Is there a specific therapy for prevention of Chagas recurrence?
So there isn't a specific, this specific therapy for prevention of Chagas recurrence is just really low immunosuppressive therapy. For Chagas itself, there is a targeted therapy, so it's benznidazole and nifurtimox are the two things that are on the market. But the prevention itself is literally just trying to not immunosuppress as much as you can.
Thank you. And the second from Professor Roden, thank you for enlightening us to this aspect. We are wondering how to you envision that cell-free DNA may help with the follow-up of the recurrent myocarditis versus rejection, or do you think this is more to alert for recurrence myocarditis?
Yeah, I think because cell-free DNA is still, working its kinks out. I think one of the things that does seem to be looking promising is antibody-mediated rejection, for example, has much higher levels of cell-free DNA than cellular rejection, and that in the future could be a thing to differentiate those two things. I could imagine or would be hopeful that there would be a similar thing for recurrence of disease potentially. Is it a thing now? No, absolutely not. And I think we'll have to see how cell-free DNA develops in the future. I think we're just at the beginning of that. As I mentioned, improved imaging modality might be better at catching sarcoidosis to begin with, and then could get better at catching a recurrence of disease as well. But this is obviously a bit of a hopeful wish for the future more than it is a proper.
If I can add something more, our experience on cell-free DNA in different post-transplant complications demonstrated that cfDNA is extremely, the level of cfDNA is extremely high in immunological disorders. In other post-transplant complications, infections, and also GER-related lung aspiration. And in a case, we had also recurrent sarcoidosis. The level was not so high. But if we want to differentiate, this could help, because in immunological disorders, CF is extremely high.
If I can be so bold, it's end of, I was just going to say, okay, then I'll highlight Sean Agbor-Eno out of Johns Hopkins has a publication that I was going to highlight in my talk, looking at using cell-free DNA, but then looking at methylation marks to determine what cells are releasing the cell-free DNA. And so they looked at native lung disease. And so perhaps I would highlight everyone to look at that paper. I think it does hold some potential promise.
That sounds like a really interesting approach.
Yeah. There is the last question for Professor Calabrese about the adverse prognostic rule of extensive pre-transplant fibrosis in sarcoidosis, reported in some works. Are there any mechanistic explanations?
So end stage sarcoidosis, as well as end stage fibrotic disease, have all a bad outcome. So there is no an explanation of correlation about the outcome of the disease. So in patients in which there is a progressive form of sarcoidosis, unfortunately, we do not have currently any explanation why some patients have a good response to steroid, they stabilize with steroid, and other have a progressive disease. We have to work on it, on this.
On that. On that. Okay, I think that you are perfectly in time. I remind you that if you have other questions, you can use ISHLT community to send questions to the pathology community and the speakers. And I would like to thank my co-chair, Lauren, and then Juliette for the supporting, technical support, and the pathology community to organize this very interesting and beautiful webinar. A lot of questions, and I think is stimulate questions and issues. So thank you very much to all speakers, and good day or good evening to all.